today's webinar on Accountable Communities for Health and the Peer Learning Laboratory. My name is Heidi Klein. In my regular job, I serve as Director of Health Surveillance for the Vermont Department of Health, and one of my primary projects is to serve as staff support for the Healthcare Innovation Project Payment Models Design Work Group, as well as the Population Health Work Group. So I will be the presenter for this morning's webinar. My plan is to share some information on the upcoming Peer Learning Laboratory and to answer any questions of yours that I'm able to. So before we get started, I'd like to go over a few items so you'll know how to participate, and I imagine that we might have some others calling in. So let's just go through the logistics first. Here we go. So on the left side of this slide, we've included a screenshot of the webinar's attendee interface, the control panel. You should see something that looks like this on your own computer desktop in the upper right corner. You're listening in on your computer speaker system by default. If you prefer to join by phone, select telephone in the audio pane and dial-in information will be displayed. So I'm going to give just a moment in case people need to switch over to make sure that they're able to hear me well and have chosen their preferred mode. If you are having any trouble, you will see there's also a chat screen where you are able to send a note to those of us who have organized the session, and please just put in a little note there and we'll see if we can help you get hooked up appropriately. All right, moving on. So we've reserved time at the end of this presentation for questions and answers. You'll have an opportunity to ask questions either by using the raise your hand feature or by submitting text questions by typing your questions into the questions pane of the control panel. You may use this option for sending text questions at any time during the presentation, and Sarah Kinsler will be monitoring that for me to see if there's anything that would require us to slow down or stop, but otherwise most of the questions we are going to hold until the end. During the question and answer session, we will unmute the lines for people who have raised their hands and allow you to ask your questions aloud. For those of you who have submitted questions in text, Sarah Kinsler will read the participant questions aloud for discussion. Today's event is being recorded. The slides and recording will be posted to the Healthcare Innovation website within the next few days, and you'll be notified when these materials are available. Please, at the end of today's event, you will be redirected to an evaluation survey. We really would appreciate it if you could complete this survey before you sign off, as we really need your feedback, both for the programmatic improvement as well as any technical improvements we need to make as we continue to use this webinar format. Finally, before we begin, I really want to thank Chrissy Geiler and Sarah Kinsler for planning this webinar and taking care of all the logistics. You guys have made it so easy for me. Thank you, thank you. All right, here we go. So today, for the agenda, we only have a half hour together. We should be fine. I just want to take you briefly through three things. We'll be defining health and population health to ensure that we're all using the same understanding. I want to share with you the Accountable Communities for Health model that's being developed and tested here in Vermont. And I want to provide an overview of the Accountable Communities for Health Peer Learning Laboratory. And again, at the end, we'll be offering some time for questions and answers. All right, so let's start. Population health defined. So as you probably know, population health has become a ubiquitous term in healthcare reform, and it often carries different meanings depending upon where you touch the healthcare system. So I thought it would be helpful to start off simple and hope that we will start with a shared understanding of the definition of population health. Here's what I offer you. That population health is defined as the health outcomes, the morbidity, mortality, and quality of life of a group of individuals, including the distribution of such outcomes within the group. So two parts. It's a group of individuals, and it's the distribution of health outcomes in that group. And it's, while not stated as part of the definition, it is implied and understood that health outcomes are the product of multiple determinants of health, which include medical care, public health, genetics, behavior, social factors, and environmental factors. This definition comes from the Institute of Medicine, the Roundtable on Population Health Improvement. I'm going to talk a little bit more about these determinants of health. I think this is an important framework that we are working within in the Healthcare Innovation Project and the population health work we've been doing. And that is really understanding that health outcomes are a product of these multiple determinants of health. In so many of our conversations historically, and at the national level, but thankfully not so much in Vermont any longer, it was presumed that access to health care would significantly change health outcomes. And yet if we look at this pie chart, what we can see is that in terms of the factors that influence health status, access to quality health care is only 10%, whereas 30% relates to one's genetic background, 15% to someone's social circumstance, 5% to their environmental exposure, and 40% to behavioral patterns. This is really important, so as we think about what we're trying to do in terms of population health improvement, we really need to understand these different contributors to health outcomes so that we are simultaneously working on improvements in our health care delivery system and affecting those other determinants of health. So I wanted to just go back again to this notion of population health and how it's defined differently depending on where one sits. And you'll see here, so for healthcare providers, population health may mean managing the health outcomes of the patients in their practice. For insurers or payers, it may be managing the clinical outcomes of enrolled patients or attributed lives. And at the community level, people talk about population health as improving the health of everyone who lives in a geographic area. What we would say for this project is we recognize that population health is all of these things. And that we have to work together at all these different levels and in our different capacities if we really do want to improve population health. So it's not a which is the right definition, but rather an inclusive definition, and that we each have a responsibility wherever we touch the healthcare system and our population to be thinking about the health and outcome of a group of individuals as well as the distribution of those outcomes among that population. So what's an accountable community for health? This is a working definition that we developed through our investigations with the Prevention Institute, and that included a scan of the national literature and best practices as well as an in-depth look at some of the innovations currently being tested here in Vermont. Our operating definition for accountable community health means it is accountability for the entire population in a defined geographic area. It includes supports for the integration of high-quality medical care, mental health and behavioral health services, and social services, along with community-wide prevention activities. It's assumed to engage a broad set of partners outside of healthcare services to improve the overall health of the population. Again, that's because we're looking at those other determinants of health, and that it identifies multiple strands of resources that could be applied to the accountable communities of health defined objectives and explore ways of potentially redirecting savings from healthcare costs for the effort. And so sort of a broad definition, we asked the Prevention Institute to help us think about, well, how would we know it if we saw it? What are the core elements that would be necessary in order to develop an accountable community for health? And these are the 9 core elements that the Prevention Institute identified. So having a clear mission, engaging a multi-sectoral partnership, having an integrated organization. Some folks will refer to that as a backbone organization. The idea is that there's an entity that's responsible for convening the multi-sectoral partnership and keeping the process of collaboration going and being able to look across disciplines, across agencies, and across funding streams in order to think about improving population health outcomes. So that integrated organization has a facilitative, convening, organizing, planning, supportive role. Another core element is having clarity about governance, who's involved in making decisions and how those decisions are made, and who is going to be in charge of keeping track of the accountability. One of the ways to agree to accountability is number 5, which are the data indicators. So a core element in an accountable community for health is that there's a core set of data and indicators at that community level to track both activities as well as outcomes for population health improvement. Those would be not only in the medical care sector, but also in those other sectors that contribute to improved health outcomes. Number 7, that there be community member engagement. 8, they found that communications was really important, having a shared sense of identity, ability to communicate across agencies and across the community about health and well-being. And the last is sustainable funding. What we have seen both nationally and here in Vermont is that we do have a lot of organizations, entities that are working towards accountable communities for health, and the question of how one sustains that beyond piecemeal grant funding has been a challenge, and so that's one of the pieces that we're hoping to explore. I'm going to skip over this one. I will come back to it later, so I'm skipping over that because I want to go back to this notion of accountable communities for health and how it fits into some of the other work that's going on here. So I'm going to pause for a sec because one of our objectives in developing the accountable communities for health model, and I'm going to go back up on what is an accountable community for health. What's not on the slide but what's really important to communicate is we are really looking to how do we build upon the excellent work that's already been undertaken in Vermont that is moving us towards ways of meeting the triple aim as we see them, which is improving health outcomes, reducing the cost of care, and ensuring the high quality of care. How do we make sure that we're meeting all 3 of those? And we know that there's been a tremendous amount of innovation over the last 10 years and leadership to move our healthcare system using the triple aim and focusing on those 3 objectives. A lot of effort is going on now that's around integrating care and services for individuals, recognizing that one of the ways that we address some of those determinants of health is looking at the person in the context of their full needs and connecting physical, mental health, and substance abuse services. And then now, I'm going to bump us down, also thinking about how we connect up with social services. So there's a tremendous amount of work being done in that integrated care management, that left-hand column, which is about how so many of our innovations have centered on creating a primary care medical home and then connecting that home with other care and services that are necessary to improve the health of the individual. So what we're trying to do in the Accountable Community for Health is show that these are all building blocks towards supporting population health improvement. So we have focused very well on integrated care management. One of the major efforts being supported through the Healthcare Innovation Project is our Integrated Communities Care Management Learning Collaborative. And as you can see, that's about cross-organization, team-based care to have integrated care for targeted individuals, usually those high-risk chronic disease folks. We also have invested in the state in Unified Care Collaboratives, which is bringing the really innovative work that is supported by the Blueprint and our emerging ACOs to figure out how they can work collectively at the regional level as opposed to just at the practice level to think about how they design cross-organizational, team-based care and also connection to other social and economic services for individuals who are already in their healthcare targeted efforts. The piece that we're adding here with the Accountable Communities for Health is that we're looking at not only those who are already engaged in care, those who are already needing high level of services and making sure that those individuals have services, but also thinking about how do we complement those efforts with some community-wide prevention strategies so that we are able to prevent people from needing the high levels of care and the intensive integrated services as a way of both improving population health and reducing cost over time. So the new piece that we're adding on really is that community-wide prevention. And one of the ways that might make this tangible for you is thinking about if we are dealing with and trying to provide support to individuals or families who are currently experiencing some negative health problems. And what we realize, for example, somebody who is struggling with diabetes. If we're trying to provide care and services for that individual and we find out that they don't have stable housing and therefore stable refrigeration for their medications, it's going to be awfully difficult for them to comply with their medication regimen, and very difficult for them to do some of the positive prevention and healthy living aspects if they don't have housing. So we would be looking for housing for that individual family. That I would put into the integrated care management and sort of this team-based work that is starting to break out all over in Vermont, which is fabulous in terms of what the Unified Care Collaboratives are doing and some of the integrated teams through the Blueprint, where they are really looking to see how do we connect with housing partners so that we can get stable housing for these individuals we're seeing show up in our clinics. If we can bring in some folks who are thinking more at a systems level community change, they would be asking not just the question of how do we house these individuals, but how do we create affordable housing for all people in the community, not just those who are currently experiencing negative health outcomes. So that would be an example where you would bring in a different partner instead of just an existing housing agency. You would bring in an economic development corporation, regional planning, perhaps somebody from the select board. It moves you into bringing forward different kinds of partners in thinking about population health improvement. So I'm going to go quickly through what the Learning Lab itself is. So as you'll see, our Learning Lab is really to explore in more depth this concept of an accountable community for health and to support folks who are already moving in that direction in building upon what they're doing and trying to hit those 9 core elements. So communities who participate will be learning with and from one another as well as some national innovators. They will help to identify practical steps and developmental stages in creating accountable communities for health. And importantly, they will not only be learning from and with one another, but they will be informing the next iteration at the state level of what are the policies or guidance or decisions that are needed at the state level in order to enable those regional levels to do the work that they want to do. So it's going to be a 12-month learning lab. A combination of peer and individual learning. We imagine that there will be some in-person learning sessions, really, and that will be learning with one another, a very interactive, consultative work among communities. And then we would have specialized webinars where we're able to bring in some out-of-state advisors or experts who can help fill in the gaps for what we don't already know locally. And then we will have some technical assistance support. So if you're in a community that is interested in participating and you would like someone to come and help convene or engage with partners that you've already convened to share concepts or to work through something, we will have someone available to provide that level of technical assistance. So it's still in the developmental process on purpose. Again, the idea is that if this is a peer learning lab, part of what we need to do is make sure that we create learning opportunities that really reflect the needs of the folks who will be engaged. So while we have some broad brush of what we will cover in those sections, most of it will be determined based on a needs assessment of the participating communities and upon the first 2 conversations that you all have with one another to be able to identify here's what we know and here's what we need to learn, and that will then inform what we do next in terms of those webinars and convenings. It should be a very dynamic process. The last piece of information I wanted to share with you is a comparison of two things that are happening. So our timing was either fabulously fortuitous or completely confusing, depending on where you sit. So we put out our notice about this peer learning opportunity almost at exactly the same time that CMS put out an opportunity for a cooperative agreement through, that they are calling accountable health communities. And so I've received a few questions about what this is and how what we're doing is the same or different and how they can build on one another. So we created this table to try and help you see the complementary nature of the two opportunities. So as I said, what we're doing is a peer learning opportunity with some technical assistance. There isn't any funding. It's really about learning with and from one another and testing out a Vermont-based model. It's a one-year commitment, and it's really about how do we connect the great work that's happening on integrating care and services for individuals with those community-wide prevention efforts so that we are bringing the best talent at all different levels of intervention in our communities to improve health. And it's open to all regions, and it doesn't matter who's paying for it. On the other hand, the Accountable Health Communities Cooperative Agreement through CMS is quite a different entity. It is coming with payment. It's a 5-year testing of a model that is, frankly, is more limited than our model. They are not really looking at those community-wide prevention activities. They are more focused on the integration of care and services for individuals. And it is available and targeting those who are on Medicare and Medicaid only, with a particular focus on high-risk beneficiaries. So I don't think they are really very different. I don't see that there's a way in which they contradict, and perhaps they could complement one another. I don't claim at all to be an expert on what CMS is offering, but I thought it would be helpful to you to just see some of those distinctions. So I think that's all I have to share with you. We'll go on to the questions time now, and I will just remind you that we can take questions from participants. You can either use the raise your hand function, or you can submit questions by typing into the questions pane of your webinar control panel, and Sarah will facilitate that Q&A. So, Sarah, are you ready to take over?
Absolutely. Thanks, Heidi. We'll now be answering questions submitted during the presentation, as Heidi said. We've gotten a question in the chat box. Molly Dugan asks, how are the geographic regions defined in the Peer Learning Lab? Are we looking at counties, or I would add health service areas?
Great. I think we have thought that it would be self-defined. What we know and what we heard is there's a lot of activity going on at the regional level in Vermont, and that there are a number of interesting partnerships and collaborations that already exist. And our hope is that any group that is interested in pursuing the Accountable Community for Health Learning Lab is building on those existing collaborations. So we have decided that it's not for us at the state level to determine where that strength lies in a community, and therefore what level or who should be the leader, because we believe that you all who are participating in those existing regional collaboratives are better poised to answer that. I hope that's, Molly, ask again if I didn't answer your question sufficiently.
Thanks, Heidi. We have another question about forming ACH application teams. Maura Graff asked if we're interested in joining an ACH in Chittenden County or the health service area up there. Do we need to build our own team for the application, or can we submit our name or organization and join a team that's already being formed?
I think joining a team that's already being formed is probably your best bet, and the way to do that is to reach out to folks who you might already be, that you might know. So if you are familiar with folks in this is Chittenden County, you said, who are leading some of the efforts at integrated care or community-wide prevention. So integrated care, you've got your designated agencies, hospitals, blueprint practices. I'm sure I'm missing a lot of folks. Your accountable care organizations on the integrated care side, along with home health. I'm going to stop my list. if you know anybody in those, and you can connect up through there, I encourage you to do that. The community-wide prevention strategies are some of those, like the Partnership for Health Improvement, the district offices of the Public Health Department, someone in the Regional Planning Commission. Those are all entities who are already engaged in some of that community-wide prevention. And so I would say try and connect up with them in advance of their putting in a proposal or a letter of interest.
Thanks, Heidi. Another question. Sarah Narkowitz from Rutland asks, is there an ideal or maximum number of regional team members that you are expecting?
So per team is what I'm thinking Sarah's asking. So how many members per team in a region? I think that's for you to decide. What I would say is when we convene, it would be ideal, to have a robust showing of your leadership. I would imagine that might be 4 to 6 people. If you want to bring more, that's up to you. The key for the learning collaboratives when we're in person is an opportunity to dialogue. And so think about how many people can actually have a robust dialogue. So I would say under 10 per team.
Thanks, Heidi. We've got another question from Joelle and Torella Falk, and it's a lengthy question, but I'm going to summarize, even though it's a great question, Joelle, and thank you, and just ask, how do you think education could fit into regional teams as a sector? And specifically, Joellen asks, we're wondering if you see opportunities to create linkages between what we do in the healthcare system and addressing the very many health needs around chronic disease management and mental health that schools are experiencing.
Right. So I think schools could be excellent partners in a team because, as we know, if we look at what are the determinants of health, our educational system and our children are absolutely essential in looking at that. And so there are ways in which some schools are actually providing health and mental health services, so that would be a great connect. There are ways in which schools can be the entry point for connecting with parents and with the community around decision making. So I see there's the institution of the schools, and then there's education as a process. And I could imagine either way that both of those are incredibly important factors in determining ultimate health outcomes. And so encouraging outreach to local educational leaders and engagement in this process could be a really great opportunity.
Thanks, Heidi. We're going to squeeze in one last question since we're almost at time, and that question is, how does the ACH model compare to the collective impact model?
Oh, really interesting. So I think from what I am not an expert on collective impact, but from what I understand, it really is about bringing people from across disciplines together to work on very complex social issues, and certainly population health improvement has multiple layers of complexity. So in that way, it makes sense. And it also, if I understand correctly, collective impact has at the core of it this idea that you have a we're calling it an integrator function. They call it, I forget the terminology, but that same idea that you need a convening partner who's responsible for the collaboration and helping people look deeper at root causes and not just at current systems. So I think it could be a model. It could be a tool for accountable communities for health.
Great. Thanks, Heidi. I see that we're at time, so if you want to wrap us up now, that would be great.
Okay, so I just want to remind folks that we are indeed, this was recorded, and we are going to be posting the webinar itself. We are available for follow-up questions anytime. You can go through either Sarah Kinsler or myself. I'm Heidi Klein at Vermont.gov. Thank you so much for your time. I really hope that you found this useful and that you will want to participate with us.